Good afternoon and welcome to OC Talk, the show dedicated to helping home health and hospice providers run compliant and successful agencies. OC Talk aims to bring you closer to reliable experts in home health and hospice and to share the latest news and information from the industry and from the Association of Home Care Coding and Compliance. I am Jan Milliman, Director for OC, and I'm happy to be hosting today's program. This afternoon, we're looking at a variety of topics during a year-end wrap-up call. And now I'd like to introduce our industry guests for this episode. We have several OC board members on the call today. We have OC Advisory Board Secretary Apryl Swafford, QA Manager with SimiTree Healthcare Consulting on the call today. And we also have our Vice Chair, Nanette Minton, Senior Clinical Coding Manager with Mac Legacy on the call. And Kelly Kavanaugh, Independent Home Health and Hospice Consultant and owner of the OTB Group, is also with us today. And Christine Mickel, Manager of OASIS and Coding with McBee Associates. Thanks everybody for joining us today. All right, we've got a lot to talk about, so let's go ahead and get the discussion started. Listeners, if you have any questions for our panelists today, please go ahead and ask them in the chat pane, and we'll try to get to as many of those as we can. All right, our first topic is OASIS updates, and Apryl is going to run through some things of note that are going on with the OASIS E1. Apryl, just let me know when you need me to advance to the next slide in your presentation.
Okay, thanks everybody for joining us. We didn't have a whole lot of OASIS E1 updates, but we did have a few, so we're going to quickly talk through those so that we can get on to other topics that we're going to talk about. They added one new item. They removed 2 items. There were 3 items that we had some revisions on, and then there was an updated skill pattern on M0102. Go ahead, Jan. So let's talk about the one that they added. It's under section O, special treatments, procedures, and programs. It is O, and section O's always confuse me. O0350, patient's COVID-19 vaccine is up to date. So the guidance says it's completed at transfer, death at home, and discharge. And we can determine that vaccine status from any available source, whether it's the patient, whether it's the caregiver, whether they have a card. I know I have a card that they gave me for my COVID-19, whether it's from the medical record, from the MD office, whatever source you have that shows where that patient did or didn't have those, you can use that. If they're not up to date, we want to ask the patient would they like to receive the COVID-19 vaccine. Now, there is no directive that your agency has to provide that, but we would want to help facilitate that if at all possible that they wanted the COVID-19 vaccine. A dash is a valid response if you cannot obtain that information, but remember Medicare expects for dash use to be rare and for us to document why it was used if we use it. Okay. Now, the catchy part or the tricky part with this question is it may differ depending on when you're doing your assessment. It is defined as the up-to-date at the time of your assessment CDC definition. I put the link there. Now, I'm sure you're looking at your PDF. You're not going to be able to click on it, but you can put that in and it will take you to the page that tells you what the current guidance is. Now note that the link that they have in the book, when you click on that, it will take you to the page and tell you that it's been changed to this web link that I have right here. So you can do it either way. You're still going to get there, but I thought maybe if you had the link that took you directly to it, it'd cut out one step. The vaccine is recommended for everyone age 6 months and older. Okay, Jan? Now, there's different guidance on what is up to date based on different age groups. So we've got 6 months to 4 years, we've got 5 to 11 years, we've got 12 to 64, and 64 and over. I did not put all those guidelines there because that's a lot of information and it's very busy when you put it on a slide. But if you need to look at that, probably most of the people you're treating, if you're like agencies that I see, are going to be in that 12 to 64 and 65 and older. But you can go to that CDC site and it'll give you all that information in table form, and you can print it out from there if you wanted to have those tables handy. But again, This stuff changes as we go along, so we want to make sure that we know what the current guidance is before we get out there. Now, currently, they they have 3 vaccines on the market. We have the Moderna, the Pfizer, and the Novavax. And again, it tells you what ages those are recommended for. Next. The next one that we had is in Section A, the administrative information. They have removed M0110, which is episode timing, and M2200, which is our therapy need. We know that our therapy need used to be used to calculate our PDGM payment. It is not used under PDGM, therefore it didn't serve a purpose anymore, so they took it off. Now, M0110, M0110, episode timing, we know that that is used under PDGM to calculate, and it is actually pulled from the claim. So even though we were doing it, that information wasn't being utilized as far as calculating the PDGM. They were pulling it from the claims. So the rule is, if there's an item on there, it either needs, on the OASIS, it's either used for outcomes, it's used for payment, it's used for value-based purchasing, or something like that. Now, you say, well, what are we doing with some of these items that they're not doing anything yet? These social determinants of health. Sometimes they'll put an item on there that they're gathering data on, because they'll gather that data, and then on down the line, they'll make some determination. It may not be an OASIS determination. It may be a reimbursement determination somewhere else, depending on what they're finding. So if there's not a purpose for an OASIS item, eventually they're going to take it off, and that's what they've done with these 2. Next. Revisions under Section GG, which is our beloved GG-0130 self-care and GG-0170 mobility. They took away the discharge goals. We will still capture the patient's ability to safely complete either the self-care task in the GG-0130s or the mobility task in the GG-0170s, but we will no longer have to do that discharge goal. Again, we weren't really using it for anything, so they're like, we're not going to make them do that. So they, the COVID vaccine took its place. I guess that's a little more work to do. So, but anyway, they took the discharge goals off, but you're still going to see the performance that you have to do on those. Okay. And the next thing that they changed or updated was, again, in Section A, administrative. It's M0102, date of physician order, start of care, resumption of care. And all they did was change the skip pattern, because prior to this, the skip pattern was M0110, which they're doing away with. So now they've changed the skip pattern to A1250, the transportation item. If you use this item, it's not going to matter if you're doing M0104, but if you happen to use M0102, just know that your skip pattern has changed. And then there was a clarification on the Section D mood, the D0150, the PHQ 2 to 9. They removed the outdated statement, and it was on there because it said don't pay any attention to the OASIS guidance because it's been updated. So they took that, they updated the guidance, and they took out the statement telling you to disregard something. That's not a biggie. So, now let's look at just a little bit of clarification on some of our overall guidance. We know that they did update that the OT can do the initial assessment and the comprehensive assessment. However, when we're talking about a Medicare or Medicaid, they still have to have another service, whether it be skilled nurse, PT, or speech. Now, if skilled nurse is in there, OT is not going to do it. So likely it's going to be either they're going to have PT or they're going to have speech in there, because OT still cannot stand alone on that first episode of care. Mandatory July 1, 2025. I know we're all excited about this. All payer OASIS data collection begins. Now, it's voluntary starting January 1 until the end of June, but July 1, it is mandatory. People already do that. May not be a big deal to you. Other people, it's going to be a big headache because they've not been doing it. On M0030, the specific instructions were changed to read: when the agency's policy or practice is for the RN to perform the start of care assessment in a therapy only case, the therapist's first visit is the start of care, the first billable visit. The non-billable nursing assessment visit must be made the same day or within 5 days. What they basically did was clarify that that one-time skilled nurse visit to complete that comprehensive assessment is not a billable visit. That's in Chapter 7, but a lot of people weren't catching on there, so they've made it very clear here. If you're just going in for that RN to do that comprehensive assessment for all of your therapists in a therapy-only case, know that that RN comprehensive assessment visit is not your billable, is not starting your, it's not your start of episode date.
Thanks so much, April. That was great.
Okay.
Thank you. Next up, we have Nanette, and Nanette is going to walk us through some coding updates and some hospice-specific changes for the new year. Nanette?
Okay, great. Thank you, Jen. Can you hear me okay?
Yes, you sound great.
Okay, perfect. So really just a couple of things in the interest of time. From a coding perspective, I wanted to just point out, if you're not already aware of this, is that when the final rule, the 2025 final rule came out, which displayed on the Federal Register on November 1st, 2024, it included a wrong low comorbidity subgroup list. Okay, and so CMS is aware of that, and they're in the process of issuing a correction notice to update the table. So the table that was in the final rule was incorrect. So the table should have replaced the neoplasm 20 non-Hodgkin's lymphoma with the CIRC7, which is atherosclerosis, including PVD, aortic aneurysms, and hypotension in the low comorbidity subgroup. However, the grouper is correct. So just be aware of that if you've already downloaded that or utilizing that information. That is correct. But if you're like me, I always print off the list because it's a nice little list and I go by that. So they're in the process of updating that. And they did have a corrected table. And so I was thinking, let me go ahead and see if I can drop that in the chat here. That might be helpful to you as well. Okay, so I put that in the chat. Hopefully that'll work for you. It's supposed to be the updated one. Regarding hospice, I think I would need 2 hours and a long dissertation to talk about all of the changes. It's just under such regulatory scrutiny. So the thing I wanted to point out, well, two things. Number one, I think we just have to be sure as an organization that we're really looking at our admission practices and what is defining that person's 6-month prognosis. What is the thing that's really going to, what is the likelihood of this patient having that 6-month prognosis? And just be sure that we're really looking at that. The second thing I wanted to point out was on November 13th, if you haven't seen this, CMS posted a memo, and the reference number is QSO-25-06, hospice. And the subject was ensuring consistency in the hospice survey process to identify quality of care concerns and potential fraud referrals. And so basically this outlines updated guidance to ensure consistency in the hospice survey process. This is emphasized identifying and addressing those quality of care concerns and potential fraud in Medicare funded hospice programs. So CMS was their goal with this memo is to really highlight their dual responsibility, both overseeing the compliance with the Medicare COPs and also protecting program integrity by identifying and mitigating that fraud. So hospice surveys, the key points really looked at 3 things. Number one, the survey process, that those surveys conducted by state survey agencies, accredited organizations ensure compliance with the COPs, and that those surveys occur at certification and recertification every 3 years and in response to complaints to really look at the quality of patient healthcare, patient safety, and administrative compliance while uncovering potential fraudulent practices. So they're always going to be looking at that. Surveyor training, CMS is really standardized surveyor training to ensure consistent practices, and they have to complete this training, supervised skilled experience, and participate in annual skills review to look at needing improvement. And then thirdly, again, survey process, surveyor training, and then comprehensive survey techniques. I'm looking at not just observations, interviews, record reviews, multiple locations, and then administrative oversight. So we know that hospices must maintain an active QAPI program, a functioning governing body, and accurate documentation. And that medical director and professional staff must meet those defined roles and credentials. And then really looking at CMS may conduct abbreviated surveys or focus surveys for enforcement, such as complaints or changes of ownership to specific issues. And then fraud referrals. So survey findings suggest fraud, suggesting fraud has to be sent to CMS for further investigations. And so not that any of this is greatly new, but this memo really was to reinforce that consistent survey practice to protect patients, Medicare funding, and looking at those non-compliance and potential fraud. And they're going to immediately implement this and communicate appropriately, and try to really implement this within 30 days. So there's actually a CMS video that they've put out. It says Quality in Focus. It's a video series to reduce common deficiencies and enhance quality care. So that's a really good thing as well. But again, just wanted you to be aware, if you hadn't seen it, that CMS is really reinforcing hospice oversight. So yeah, that is all I have on that. Jan?
Great, thanks so much, Nanette. April, we've had a couple of questions come in from listeners. They're basically the same question. Folks are wondering if they start doing the OASIS data collection for all payers voluntarily in January, will that data be submitted to CMS and used towards those publicly reported outcome measures?
That is a good question that I'm gonna be honest, I don't know the answer to. Let me dig around and find out for sure, because I don't want to say one way or the other, just guessing off the top of my head what I think they might do. And then I will get you that, Jan, and you can get it out. Unless somebody else on here knows the answer to that.
We can follow up with those folks afterwards. Thanks so much, April. I appreciate it.
I'm sorry I wasn't prepared with that.
Oh, that's all right. Questions come up. That's fine. All right. Well, next up we have Kelly, and Kelly has some pointers for those GG item accuracy issues that folks have been having. Kelly, just let me know when you are ready for me to switch to the next slide as you go through your section here.
Okay. Well, I have to agree with Nanette that I could go on for, at least 2 hours on the GG items. So I will do my best to keep it brief. And, April mentioned that we are getting rid of that DC column on the GGs, which is an amazing thing. And I think will be somewhat helpful because I think it added to the confusion with so many scores going on with the functions. So I think that's going to be an amazing help for those of us who gather this data and review this data on a general basis. But we are still going to have 2 sets of functional scores because the 1800s, unfortunately, are not going away, and they are still tied to payment for the episode. So we're not getting rid of them, and they are still important. But what we are adding, which is new, which is what I wanted to focus on today, briefly for you, is the discharge function score, which is part of your value-based purchasing for 2025, is now going to be set off of the GGs instead of off of the 1800s. So they are going to indirectly affect your payment because of your discharge function score being part of your agency's total performance. For currently 2024, your discharge, the performance for your function is based off the 1800s. and it was 17.5% of your score. And now for 2025, your outcomes are going to be based off of the GGs, and they will be 20% of your total agency performance. So they are going to be weighted higher and affect you differently. So let's talk about how they're going to affect you and how they're going to calculate this thing, because there is a component here that did not exist in the past as well. So basically what they're doing, it's all about the math. Okay, so hang in here with me, those of you who don't love math, because it is all about the math. So your discharge function score is going to be based off of these 10 items, which you see on the slide here. And if you'll notice, there's no bathing in here, there's no dressing in here. So these are very different functions that they're looking at for our discharge function score for 2025 as well. So these are your GG items that are going to be the ones they're going to be looking at. So we need to pay attention to these for sure. And one note I want to make down here at the bottom, we've got 2 items, the walking 10 feet and walking 50 feet with 2 turns, which are for ambulation related. So if your patient does not ambulate, you can jump to the next slide, Jan. If your patient does not ambulate, then they're going to use the wheel 50 feet with 2 turns, and they're going to use that score twice in that patient's calculation. So just be aware, those are some important items you want to be sure you're getting correct, because it's going to be a bigger portion of your calculation. So basically what they're doing, they're just going to be adding up these numbers. So it's a basic calculation. So we score these 0 to 1 to 06 is how the discharge, those items are scored. So they're basically going to add these up. So for example, if your patient was all ones, they were dependent on every one of those items, then your patient score is going to be 10. If they were completely independent with all those and we scored them all 06s, then the maximum score then would be a 60. So that's where we're talking about the 10 to 60 range. What you don't see in there is all those activity not attempted codes, your 07s, your 09s, your 88s, and your 10s. And those are going to be ones that if those items are used on your calculations at both start of care, resumption of care, and discharge, then Medicare is going to have to impute a score for you on your behalf, because it doesn't work in the math. So you should avoid using those whenever they're possible, but there are times and places for all of them. That's why they're available as scores. So you can't completely eliminate them. I know that would be impossible in a lot of cases, especially the 09s. If they can't perform an item, and they never could, they never will. Paraplegics are never going to walk again, no matter how much we give them therapy. So there is a time and place for all of them, but avoid them if you can, especially like if the patient refuses and those kinds of things. If we can come up with a score by other means, then we'd want to come up with that score ourselves rather than allowing Medicare to impute that for us. So like I said, time and place, but do your best to get a score in there if at all possible. There's a lot of things around the scoring of these items, which I'm not going to have time to go into today, but you certainly want to be sure that you're getting education, your clinicians are getting education on how to score these items properly to get the best picture you can on your patients. The discharge function score is something that Medicare is they're going to set the bar. So no longer are we required to answer those discharge items, but Medicare is going to set that discharge expectation for us. So they are going to use the scores that we give them on our OASIS. They're going to do some data calculation and some risk adjustment to that data, and they're going to come up with the discharge function score that they expect us to meet on our patients. So it's going to be a challenge. It is something that we have to strive to meet or exceed, because that's going to affect your agency's total performance for value-based purchasing. So I have an example, I believe, on the next slide. Yes, here's an illustration for you. So when we do our OASIS at start of care, the patient scored 40 points for those 10 reported items. So when Medicare does their calculation, their risk adjustment, they look over the scores. they determine our discharge function score should be a 55 for this particular patient. So when your agency completes the discharge OASIS and computes the final, GG information, if you scored equal to or greater than 55, then that would be a positive or credit earning situation for the discharge for that patient. And you're basically building a fraction here of how many of your patients meet or exceed that functional score. And then you get a percentage for your agency, and that determines your total agency performance for your patients overall. So if your score is under 55 for this particular patient, then you would not meet the expected discharge score, and that would be a negative impact towards your total agency performance, because that patient would not fall into that fraction you're creating of your patients, or your percentage of patients who met or exceeded their discharge goals. So it would go against your agency's total performance. And then on the final slide here, this is just a list of all the things that are used for risk adjustment. So one thing I want to point out here that's very important to keep in mind, every one of these risk adjustment items that they're going to give you, quote, credit for your patient is all OASIS based. So the information that we give them is what they're using to risk adjust their patient. So if we give them bad information on our OASIS, then our patients are not going to be risk adjusted accordingly, and it could affect that discharge function score that they predict, and it could affect our ability to meet that score. So when I do education, I always tell everybody everything is important. It's all important. The entire OASIS is important, and this is the reason why, because it's going to be risk adjusted based on the information we give them. So for example, one of the important things you need to know, if they're going to use the diagnosis that we give them. However, the only diagnosis that they're going to see, because this is OASIS based, is the top 6 diagnosis on the list, because those are the only ones that we transmit on the OASIS. So all 25 or however many more you might have are not going to be used for risk adjustment. They still will be used for payment and all the other things that diagnoses are used for. So they're still very important, but only the top 6 are going to get you risk adjustment for your discharge function score. The incontinence plays a role. Your BMI score is another thing you need to be aware of, that the BMI score is only going to be used if you put it in M1060 height and weight. They will not give you credit, even if you put in your top 6 diagnosis the BMI score code, they will not give you risk adjustment for that BMI unless you put the height and weight in M1060. So if you have a patient that's 400 plus pounds, BMI scores in the 40s, you want to be able to have that risk adjustment, for multiple reasons, because that is going to affect your outcomes with your patients, your joint replacement patients, all those patients that it will definitely affect the outcome ability of your patients. But if you're not putting the height and weight in M1060, you are not going to get risk adjusted for that patient's BMI score. So very, very important to complete every part of the OASIS as accurately as you possibly can, because it will indirectly affect your payment. Because if your total agency performance is not where it should be, you could be at risk for 5% of your total payments for your agency, and that affects all of your patients going forward. So you don't want to be in that predicament. That's all I have, Jan.
All right. Thanks so much, Kelly.
You bet.
All right, Christine, you are our final panelist for today, and you have a face-to-face refresher for us. Always a tricky topic, so thanks so much for bringing this to us today.
Sure. Yeah, the face-to-face, I think it continues to be a hot topic in 2024. So I just thought I would bring today some tips to assist our home health agencies with having a valid face-to-face. It'll be brief today, so I'll just get started. So we'll start with some key requirements. And again, these are just tips. It's not an all-inclusive here. And starting with timing, And we're thinking about the timing for that face-to-face. That face-to-face visit with the provider must occur within 90 days prior to the start of care or 30 days after that start of care. And we're going to think about those documentation standards for that face-to-face visit note. It must be an encounter note, not just that attestation certification form that's filled out by a provider. It has to be that encounter note. That note must be signed and dated by the provider. And that encounter must document the reason for home care services, must support both homebound status and medical necessity. And to think of some specific scenarios here, if that face-to-face, just moving forward here, if that face-to-face is performed within 30 days after the start of care. So this is just a scenario here for us to think about. If the face-to-face is performed within 30 days after the start of care, that face-to-face visit, that must be performed by the certifying provider. When we have referral source variations, when we're thinking about, is that referral from community referral or an inpatient referral? If it's a community referral, that same provider must sign the face-to-face and the plan of care. If it's an inpatient referral, different scenario here. An inpatient provider may sign the face-to-face, and a different certifying provider may sign that plan of care. The provider following the patient can certify the face-to-face using the inpatient visit note. We want to think about consistency in the dates of the attestation statement. So we do see that attestation statement in our documents. And when we see that attestation of the face-to-face encounter date, face-to-face encounter, that face-to-face attestation, the attestation date must match the encounter date itself. So we have to see consistency there. When we see that attestation statement, the date that's listed there must match the date of the encounter. There's so many things when you think about trying to check all the boxes and making sure that cross-referencing dates and signatures and which provider can, which face-to-face, which visit can we use for the face-to-face, which encounter note. So many things to think about, and really having those in line and having a good process, I think, for your intake department, and have those processes set up for your agency can really help, and can really help your agency be set up for success, to have a valid face-to-face, prevent denials, prevent any hiccups in that process. So that was just a couple tips today to help you with obtaining a valid face-to-face. That's all I have.
That's great. Thanks so much, Christine. We get lots of questions about that, so appreciate you bringing that to today's episode. And thanks to everybody for everything you shared. All good stuff to get us ramping up this year and starting off next year with knowing what we're up to and keeping things compliant and successful. So I just have a few more sections before we wrap today's call. It's time now for our product spotlight. If you are looking for a way to continue to keep up to date with the issues that impact the industry, you might want to consider a subscription to Home Health Line. This weekly publication brings you home health specific news, analysis, guidance, and specific tools that can help you to increase referrals and profitability during times of increased competition and regulatory scrutiny. And OCC members receive a 15% discount on subscriptions to Home Health Line. So go ahead and click through the link in your handouts to start your subscription today. And now it's time for me to share a little bit about what's new with OCC. And this is a segment of our show where we share updates from the Association of Home Care Coding and Compliance. Here at OCC, aside from face-to-face, the broader concern we hear the most about is issues with inadequate documentation. And in order to create training and tools that might help with this issue, we've created a brief survey to gather information about the way home health coders approach documentation to support code selection. Please follow that link in the handouts to take the survey, and feel free to share that link with any colleagues or other folks in the industry. We want to try to gather as much information as we can. It's a really brief questionnaire, I think maybe about 5 questions there, and the more information that we can gather, the better. And I'm just seeing that we have a couple of face-to-face questions that have come in here towards the end of the show. I'm going to follow up with our speaker, and we'll circle back with some answers for these questions that have come in late, because I know we've already gone over our time today, but we just had so much we wanted to share today. So folks, if you had a question in the queue, I'll be reaching out with an answer soon. We hope you enjoyed this episode of OCC Talk, and thanks to our panelists again and for all the great information you shared, and thanks to all of you listeners for tuning in. We hope you'll join us again for our January 27th call, when we'll be taking a look at the home health potentially preventable hospitalization measure. In the meantime, if you'd like to re-listen to this episode or a previous one on the go, you can now find OCC Talk on your favorite podcast app. Or you can also listen to the recording of this episode and access the handouts on the OCC website. And if you have any suggestions for future guests, topics, or ideas about the format of the show, please send me an email at jan.milliman@decisionhealth.com. Thanks so much for listening. We're wishing you all the best as the year winds down, and we'll see you again next month. Take care, everyone.